I'm David Lombardo, and this is WCNY's The Capitol Press Room. Back in April, we highlighted an obscure state healthcare billing process that is potentially getting overhauled in the state budget, as Governor Kathy Hochul is looking to change what's known as the dispute resolution process used for determining reimbursement rates for out-of-network emergency services. We previously heard about the abuse and waste concerns with this process, which you can find at capitolpressroom.org or wherever you get podcasts. But now we're going to consider the merits of the status quo as we're joined by Dr. Thomas Lee, Chief Executive of the Medical Society of the State of New York. So the complaint that's raised with the current so-called independent dispute resolution process is that it's designed in a way that results in payments to providers that are generally on the higher end of the spectrum compared to what, say, private insurers or Medicaid plans might typically pay for these services if they were, say, in-network, with the governor's budget arguing that the status quo is ripe for quote-unquote abuse. What do you think of the way disputes over reimbursement costs for providers are resolved now? And ultimately, do you feel like it's fair?
Okay, we had to give you a 30-second history of the No Surprise Act for the state of New York, which I helped pioneer in 2012 to 2014. Back then, I called the Dark Ages. ER in the rural area and metropolitan area, urban area, have no specialist coverage after hours at night or even during the day. A lot of patients are suffering from injury, illnesses, not being able to access care timely, and they had to be transferred tens of miles, 20, 30, 50, 100 miles away to get care. Now, this bill was really passed to assure quality access to specialty care in rural and metropolitan hospitals so patients can access care in the community that I live in and receive expeditious care. It provides a fair balance between the provider and the insurers, setting up independent dispute resolution process that is independent. You heard that correctly. Nobody controls the process. Both sides submit evidence for consideration, and the independent panel comes out through a baseball-style arbitration, determine what is the most appropriate payment amount. If they agree with the insurance company, they win. If they agree with the provider wins. So that provided needed access for patients in our inner city and rural area. Now, fast forwarding 10 plus years, the process has been working well. Yes, the cases might have gone up because physicians are not aware of the process in place. And number two, the cause of the increase in cases and hence the cost to the system is a result of number one, insurers not having adequate, sustainable, livable contract for physician practice. So they have to go out of network to survive. One. Number two, when the claim is adjudicated, they do not submit for negotiation after the EOB or explanation of benefits is issued with a small initial payment. There is no negotiation offered. Three, when it goes to independent disputes resolution, the process itself is not well attended by the insurance industry. They did not provide data, they don't show up, or they provide data that the dispute resolution panel disagree with, right? So end of the day, that is what prompted the increase in the utilization and overall payment. So I will gather that, are they going to be some outliers? Yes, but that's what the system is supposed to weed out. And if our friends in the insurance industry were to come on board and provide the necessary data, hopefully we'll meet in the middle somewhere, right? That is why IDR is set up, is to encourage discussion, encourage negotiation.
You brought up the history of the underlying legislation here, and talking with stakeholders, one of the things that they point out as a maybe unintended consequence of the way the bill was written is that it has been interpreted to include Medicaid coverage. And stakeholders say this was never supposed to include Medicaid. If you look at the federal companion version of the No Surprises Act, it specifically makes a point that it does not apply to Medicaid or Medicare. So what do you think of this idea that Medicaid should be removed from the independent dispute resolution process as Governor Hochul proposed in her budget?
I think that's the fallacy, right? What is a predominant insurer in the inner city and the rural area in the state of New York? Medicaid. Now it's managed Medicaid, to be more specific. Now, if you were to include that in part of the governor's budget, that means that Medicaid, HMO, or managed Medicare is no longer part of this process. Then you take away the original intent of the legislation.
So you feel like the intent was to cover Medicaid, even though the stakeholders that we've heard from basically say No, that was not what we intended with the Medicaid exclusion initially.
Well, there was no specific exclusion, and that's why the Department of Financial Service specifically opined
Mm.
back then that no, it's not supposed to be excluded. You can look at the actual opinion, and that's not me talking; it's the Department of Financial Service.
So, if the status quo remains, is there any reason for healthcare providers to engage in good faith negotiations with health insurers when they say, hey, we'd like to bring you in our network? Because I imagine if I'm a healthcare provider and I look at the status quo and I say, well, you're offering me something that is much less than what I might be able to get through independent dispute resolution. So, does the current system encourage people to stay out of network?
Well, actually, first of all, the current system does neither. It is supposed to encourage negotiation pre and post IDR, right? When you are out of network. That's make draw a distinction. The percent at one point I was going to get to is that previously the insurers used to come to the table 30 to 60% of the time, depending on the insurer, to negotiate. So the claim never go to the actual process itself, right? Now that negotiation rate is down to 6%. So when you want the process to fail, what you do is that you stop negotiating, which is the tenet of the IDR, right? You want to encourage people to talk reasonably, reach a common ground, move on. But that's not occurring because our friend in the insurance industry is not offering to negotiate at all whatsoever in the cool down period or the mandatory negotiation period. They're not submitting any offer. And when they submit a $0 offer, you see something on the form, you'll laugh. How can any service be $0? That's just unreasonable.
Do you feel like that's emblematic of their broader approach, or could that be a one off or an outlier to a certain degree?
Oh, it's not.
Mm.
We have seen many, many IDR forms being filled out with zeros. And how can you say any service is worth zero, right? And of course, that's basically saying that this service is worth nothing or unjustified. Even there's medical necessity through the ER or anesthesia service, inpatient, whatever that might be, right? I think there are ways we can, as I say, if physicians have livable, survivable contracts where they can pay their employee themselves, the rent, malpractice, and all the overhead costs, it's much less bothersome and much less administrative burden to have a decent contract and move on. Also, when you go get physicians squeeze out of practice into employ a model, look at last year's time union study in February 2025. When they get employed into a vertically integrated system in North Country, cost goes up 900%. Western New York, 400%. Downstate New York, 230 to 250%. That is where your cost driver is. Physician payments is still pittance. IDR is less than 1%, 0.1% in most instances for healthcare spends, to be frank.
Well, before we move on, let me reintroduce you for listeners just joining us. I'm David Lombardo, and this is WCNY's The Capitol Press Room, and we're speaking about the state's independent dispute resolution process used for determining reimbursement rates for out-of-network emergency services. And our guest is Dr. Thomas Lee, Chief Executive of the Medical Society of the State of New York. So how should we think about the examples that are flagged by, say, insurance companies where they say,
Mhm.
hey, something like a back surgery, for example, the typical Medicaid fee schedule would be $3,000, and they're ended up getting $500,000 through the independent dispute resolution process. I mean, that is not even in the same ballpark as the traditional Medicaid fee. So it seems like if you are going to provide services to someone out of network, you have an opportunity to make more than, I'm trying to do the math in my head and my brain's breaking, trying to think about what an exponential increase that is over the Medicaid rate. So, I mean, is there a reason why someone should get that much more than the Medicaid rate?
Well, I think number one, the insurance industry had to bring in their data, right? If you bring data to support your position, once again, the panel agrees with you, you win.
But this would be like a
They don't
Medicaid
split.
example that I was highlighting. And so you're saying that do the Medicaid plans not show up as well?
Well, listen, a lot of plans don't show up or they don't provide data. All
Gotcha.
right. And I'm hoping that they're learning now they need to show up. I tell all of my friends in the insurance industry when I meet up with them, I meet up with them regularly, by the way, all major carriers, that please, everybody needs to follow the rule. You need to show up, you need to provide data. And in fact, I encourage you to negotiate beforehand and get it out of the way. And that's my words of wisdom, which I don't have many, by the way, to them that this is really a mutual process, right? And how do you deal with quote unquote outliers? Then you can tweak the methodology such that X percentile what is not accepted, right? And that's what statistics and data-driven payment system is, right? And I'm sure that data is readily available. We have Fair Health. We sure has all payer database. Everybody has their own data that they can bring to the table to make this a more robust and middle lane approach.
Are there reforms to the system that, say, the Medical Society of the state of New York would be open to? Or do you feel like the status quo is working and there is no reason to open this process up at all?
I think it's first of all important to protect patient access in this inner city and rural area emergency room and coverage, right? Number one, first and foremost. Now, are they tweaks that we would support? Yes, do bring it to the table. One thing we would support is a mandatory 30-day cool-off period before you file state IDR. Both sides must come to the table with their best argument prior to IDR filing. And it needs to be an earnest goal to reach a resolution, either through mediation or some other mechanism, right? So I think that will be one thing that will benefit both sides. So the number of cases will be down, and hopefully you will see less outliers. And listen, and I say the benchmark, I think, to go from first of all, Medicaid rate for covering specialty services is unsustainable. Medicaid rate is set at the level such that, for example, you do a craniotomy, right? Emergency brain surgery for $700. That includes 90-day global. That's an artificially contrived rate. How can you stay in business when a neurosurgeon in Nassau and Suffolk pays $350,000 for professional liability premium? You cannot, right? And so that's where the system is flawed. You cannot point to Medicaid rate and say, well, that really is the right metric because that is an artificially contrived data set that really cannot sustain a reasonable practice whatsoever.
And it seems like this also underscores the problem with the Medicaid rates more broadly and how they are not representative of care. I mean, you highlighted the issue with specialty care, but I think it would be fair to say that there are problems with the Medicaid reimbursement rates for even the most basic of services, right?
Actually, Misny has made great stride with the help of the governor. We agree on something, right? We increased Medicaid rate for outpatient visits at facilities and outpatient services from 60% of Medicare to 89 and now 90% of Medicare for these facility-based outpatient services, right? So actually, it's more livable wages. But then again, who benefit most? The vertically integrated system in hospitals, right? You really want to keep services at a community level, at your mom and pop bodega, if you call it, or community primary care services, right? And but I think that was the first right step. Make sure primary care is covered. Their evaluation and treatments can prevent more dire consequences and illness. So I think that is the right step to take. But on the other hand, for the rest of the services, they certainly have not been adjusted and does not reflect the cost of doing business whatsoever.
Well, unfortunately, that's all the time we have for this conversation. We've been speaking with Dr. Thomas Lee. He's the Chief Executive of the Medical Society of the State of New York. Thanks so much for making the time, Dr. Lee.
Thank you for having me once again.
Thanks for listening to today's edition of the Capitol Press Room. For an insider take on what's happening in state government, check out our Dispatches from Planet Albany show, available wherever you get podcasts or at capitolpressroom.org.
Join us again for Capitol Press Room, a production of WCNY Connected, Syracuse.